For decades, cardiovascular prevention has focused on one core target, LDL cholesterol. Not because LDL is bad in theory, but because in practice, it drives atherosclerotic plaque formation. The lower the LDL, the slower plaque grows. And below the critical threshold of 70, plaque doesn't just slow, it stabilizes. Clinical data consistently show that when LDL is reduced below 70, coronary plaque progression drops dramatically. LDL under 50, and there can be regression. This is an incremental benefit. This is a biologic inflection point. Below 70, plaques become smaller, less inflamed, and more stable. And in individuals without established cardiovascular disease, pushing LDL even lower may be the difference between never forming plaque at all or spending decades managing it. Statins do have a place. They reduce LDL by inhibiting cholesterol synthesis in the liver, and at low doses they provide a meaningful anti-inflammatory benefit along with LDL lowering. They do have a helpful effect on the lining of the blood vessels by reducing inflammation. At moderate to high doses, though, statins come with significant trade-offs. They increase coronary calcium scores, not necessarily because plaque is growing, but because soft plaque becomes calcified. This calcification may stabilize plaque, but it also complicates imaging, risk assessment, and long-term vascular flexibility throughout your entire body. Statins also reduce coenzyme Q10, a crucial nutrient your body needs for mitochondrial health and energy production. They work by blocking cholesterol production in the liver. Your body uses this cholesterol as a building block for many things, so blocking it upstream has downstream effects outside of just lowering LDL. Statins are effective, but they are blunt instruments. PCSK9 inhibitors represent a fundamentally different approach. They are monoclonal antibodies, precision tools designed to enhance LDL receptor recycling, dramatically increasing LDL clearance from the bloodstream. They help your liver do what it did when we were younger, naturally clear the cholesterol and LDL from our bloodstream. No interference with cholesterol synthesis. No mitochondrial stress. No signal toward coronary calcification. Just powerful, clean LDL reduction. In trials, PCSK9 inhibitors consistently lower LDL by 50 to 60%, often driving levels into ranges once thought impossible without increasing coronary calcium. That's not just effective. That's elegant. Plaque rupture is what causes heart attacks. Plaque rupture is driven by inflammation, lipid burden, and mechanical instability. Lower LDL reduces lipid content that lowers inflammation and stabilizes the fibrous covering of the cap, making it more resistant to rupture. Lower LDL means more stable plaque, less chance of rupturing. By removing PCSK9 signaling being produced by the liver, this avoids unintended downstream effects. This is not about chasing numbers, it's about changing plaque biology. Cardiovascular medicine is moving away from one-size-fits-all. The future is precision, low-dose statins when inflammation matters, PCSK9 medications when maximum LDL lowering and plaque stabilization and reversal is desired. Aggressive targets before disease ever begins because the safest plaque is the plaque that never forms.